Hello and welcome to this webinar. I'm Fiona Godlee, Editor-in-Chief of the BMJ, and it's my great pleasure to welcome you to our webinar, Building Back Greener, with the title, What is Healthcare Role in Creating a Sustainable Future? We have some wonderful research that we will be publishing and launching at this webinar. And just as some introductory remarks from me, and then I'll hand over to my colleague, Dr. Kamran Abbasi, Executive Editor of the BMJ, to actually chair and introduce our other speakers. I just came back from COP26 in Glasgow. It was a fascinating experience. I was actually at the Earth Summit in 1992, which was the precursor to the COP. So that's nearly 30 years ago, in Rio de Janeiro, when the first United Nations framework was developed, and that led to the first COP a few years later. It's been very interesting to look back at the diary that I wrote in the BMJ in 1992 and to recognize that really at that point in 1992, the science was pretty clear. That actually it's not that the science has changed in very much about the role of human activity in contributing to the global climate crisis. But what has changed is the speed of response, which arguably, almost certainly, has been far, far, far too slow. But over those years, what we have seen is we've seen the health community voice growing in confidence and urgency around this issue. And that's what many of our speakers have been engaged in over the years, and as has the BMJ, publishing about the importance of health and healthcare as a leading, having a leading role in the way forward. I think the important thing about what you're hearing from COP now is the very confident way in which people are saying the climate crisis is a health crisis, and that is a shift, and we must absolutely keep stressing that point. And the reason those things are important is that the harms to health are happening now around the world: floods, fires, conflicts, displacements, all of that due to extreme weather events and changing in weather patterns, but also direct effects of the burning of fossil fuel in air pollution and water pollution. And so that's obviously health is being harmed at the moment. The second reason is that there are many benefits to changing the way we live to more low carbon lifestyles in terms of active travel, better diets, more human friendly cities. All of those things can be enormously beneficial to the future. And the third thing is that healthcare itself contributes a great deal to the carbon footprint, the world's carbon footprint, about 5% of carbon coming from actively from healthcare provision. And that's really what we need to tackle in order to be part of the solution rather than an ongoing part of the problem. And the final thing is that the healthcare community has a really important and influential voice that needs to be raised. And we at the BMJ have been doing what we can to educate and encourage and inform healthcare professionals around the world so that they feel confident to talk about this issue and that they really can take it to their patients and their peers and their managers and the public in general, making it clear that action is needed now if we are not to be engulfed in climate catastrophe. So with those words, let me hand over to my colleague, Dr. Kamran Abbasi, Executive Editor of the BMJ, to lead us through the rest of the webinar. Thank you very much indeed.
Fee, thank you very much for that wonderful introduction. I think you've captured everything that we're going to hope to talk about today. I just want to contextualize what we're doing at the BMJ. We've got a whole tranche of work that we're putting together on climate change and health. We've published a good deal of it. We're commissioning a great deal of it as we speak, almost, it's an ongoing commitment for us. And today we're going to talk about 3 of the papers that we've just published recently, 2 of which have kindly been supported by the World Innovation Summit of Health for Health, which has partnered with us on those pieces. But first of all, I'd like to go to Renee Salas, who's on our advisory board for climate change at the BMJ. And Renee is a fellow at the Harvard Global Health Institute. Renee, you're live at COP26. Fee just contextualized very well the potential role of healthcare and health professionals in achieving a sustainable future. Do you get a sense that there's been a shift in people's thinking?
Yes, well, thank you. It's an honor and privilege to have been here since the from the very start. And I'm actually reporting live here from the Action Hub, and you literally see the globe behind me. And so I think there is an increasing recognition that the climate crisis is a health crisis, first and foremost. Now, this is my second COP, but even in those 3 years since Madrid, we are seeing more and more individuals echo that cry, and from people outside of the health community, from decision makers, recognizing that this is first and foremost a health crisis. So some of the items that are really tangible here are the fact that there are more health professionals here than ever before, and that spans the globe. And I think one thing that is most inspirational for me about COP is being able to walk around and see people from around the world all brought together through this common goal of action on the climate crisis, because there is no greater prescription for improved health and equity than action on climate. In addition, just yesterday, we had the very first COP26 presidency event on health on the main stage. And during that event, there are 50 countries committed to the WHO COP26 health program. And those 50 states included the United States, long overdue, in addition to Canada and countries from every region of the world. Now, 14 countries committed to net zero by 2050. But we have seen a lot from the NHS and Nick Watts, who's leading that work, that they are really setting a path forward for how to get there. And their aspirations are much bolder. And there is the first zero emission ambulance actually here outside in the COP venue. So we actually have emergency department and healthcare hardware here at COP26 for the first time. So I will end with just saying that this conversation is very well timed. And I'm really excited for us to engage on this, because action on climate change is a part of our mission, and we have to keep our goal on mission, which is 100% emissions. And I believe that decarbonization in the healthcare sector can be a catalyst to get us to the societal change we need. Thank you.
Renee, thank you very much. That sounds encouraging. I think we'll discuss some of those issues towards the end of the session. I'd like to bring in our authors now. So I'm going to start with Jody Sherman, who's at Yale. Jody, you wrote a paper for us on net zero healthcare, a call for clinician action, very much speaking to what Renee has just been talking about. Tell us about your paper.
Well, firstly, it's worth reiterating the most recent 2021 Lancet Countdown on Health and Climate Change report notes that globally, healthcare is responsible now for 4.9% total global greenhouse gas emissions. That's rising at a rate of 6% annually. We must address how we deliver care if we're ever to reach net zero healthcare. So we've heard about the planetary health framework. We really put forth what's called the planetary health care framework. Planetary healthcare requires embracing an expanded notion of the principle, first do no harm, beyond care for individual patients, to a duty to protect Earth's natural systems on which intergenerational health and well-being depend. This planetary healthcare framework lays out 3 strands of action. The first strand, matching supply of health services to demand. So what do we mean? Inappropriate or low value care is ubiquitous, or that which the harms or costs outweigh the benefits. Low value care is that which is unneeded, unwanted, clinically ineffective, unaffordable, inequitable, and irresponsible in its use of resources. This includes both overuse and underuse of resources. And globally, 1/4 of healthcare is deemed low value. That includes both high and low income nations. So the second strand of action is around reducing emissions from what's embedded in health services. So this includes our hospitals and our supplies, and how we can act as clinicians includes better coordination of care, moving to community-based care, telehealth where appropriate, including addressing issues of technology and broadband access or equity. And we must leverage our collective voices to influence industry. The third strand is around addressing the demand for health services moving upstream. That means addressing the social determinants of health, promoting health, preventing disease, and improving how we manage chronic disease. So we actually lay out a ladder of engagement from local to global action. Every clinician can do something, whether it's changing their clinical practice, working within their clinic, their hospital, their health system to change standards, and procurement policies, are getting involved with professional standards and policies at a much higher level, professional level, and regulations and regulatory writing to make a difference. We provide a table with extensive examples, and I encourage the listeners to read it. I think importantly, we take away lessons from the COVID pandemic. During the first months of the pandemic, the global medical community came together at a historic pace, rapidly sharing information, redesigning modes of care, conserving and innovating resources, moving towards a circular economy. Many of these solutions are the same exact things we need to decarbonize healthcare and improve resilience to the climate crisis. And so by comparison, having healthcare's emissions by 2030 seems entirely feasible, but we really need the political will. Now, some takeaways I get from COP. It's great that there are so many health systems taking this net zero pledge, but it's not enough. There must be timelines, there must be emissions reduction goals. We require infrastructure, standards of accounting, and accountability tools in place, and we must share best practices. Without these, we risk not going far enough nor fast enough. Thank you.
Jodie, thank you very much. I think we'll come back to that point about how we actually get action at the end. I just wanted to ask you, I mean, it's implicit in what you said, but how do we get health professionals to take this on?
Well, I think firstly, it has to be part of our education. It's not currently. I mean, in the UK is leading in this, but in the US and other parts of the world, sustainable health practices is a new concept. But I will tell you, anyone delivering care is completely aware that we must be causing some harm to the world. Things are coming from somewhere, they're going somewhere, particularly in the US, other high-income nations. We waste a lot. A lot of this is driven by the need to prevent infection, which is fundamental to what we do in healthcare. But a lot of what we do is not evidence-based in terms of moving towards single-use disposables, a lot of policies that drive waste. So how do we get involved? Well, firstly, we can stop wasting. That's number one in our clinical practice. The other is to identify those things that are driving poor practice and get involved with those. So little actions from what I do on a daily basis to how my organization does business to how my professional society drives guidelines. I mean, you can get involved at any level.
Jodie, thank you. You mentioned high-income countries. I'd like to move now to kind of expand that theme to the challenges of low and middle income countries. I mean, clearly there are some similar challenges, but some very different ones. And I'm going to go to Fawzia Rashid and Jerome Baddley and their paper on decarbonizing healthcare in low and middle income countries and the potential pathways there to net zero emissions. Fawzia and Jerome.
Great, well, Jerome is going to start, but thank you, and then I'll take over.
Great, thank you.
So I think all authors here today agree that healthcare is carbon-intensive activity. However, the data that we highlight in our paper suggests that healthcare in low and middle-income countries is on average 3 to 4 times more carbon-intensive per dollar spent than healthcare in high-income countries. And as we work to deliver on the international commitments to universal health coverage, it's actually in low and middle income countries where healthcare is going to see the most rapid growth over the coming years. Full delivery of the targets on universal health coverage under a business as usual high carbon paradigm could add around 16% to the global carbon footprint of healthcare. That'd be almost a 1% increase in global carbon emissions. So, however, we argue that it should be possible to achieve net zero in LMICs while delivering this necessary growth in healthcare. And indeed, we argue the emissions reductions are absolutely essential and integral to growing healthcare provision in LMICs. So in our paper, we also highlight that carbon reduction almost invariably comes with co-benefits in terms of reduced costs and improved health. So whether that be swapping fossil fuel generators for solar panels, SUVs for EVs, or patient travel for telemedicine, investment to grow healthcare in LMICs that is greener, cleaner, and more efficient will result in more healthcare for every dollar spent, less harm from impacts such as air pollution, and critically, less harm from climate change. So all the knowledge and the technology that we need to cut these emissions already exists, some of which we highlight in our paper. And the challenge is often actually putting knowledge in the right hands and investment in the right places. And we need to make urgent progress on both fronts. So we argue in our paper that failure to link all investments in healthcare with progress on carbon reduction can actually undermine achievement of universal health coverage. And actually a smart alignment of priorities can help address global health inequity of climate change while addressing also the current inequalities in healthcare.
Thanks, Jerome. Fawzia.
Right. Yes. So we present some of the numbers in our paper, and we've done a lot more since. But when you crunch the numbers, the costs of decarbonising healthcare, and at different levels of the health system, which we've done, the good news is that we can certainly approach, if not get all the way to net zero, which is a surprise. And that keeping people healthy, prioritizing health promotion, disease prevention, and bringing services closer to home, which we've all talked about, really makes more sense than ever. And it is partly a question of using available technologies in smart ways. But besides a sort of win-win for patients, finances, staff, we shouldn't forget that another aspect of this is that we, through doing things slightly differently, which we elaborate a little in the paper, but can do as well elsewhere, is that we widen access to health through, for example, establishing off-grid facilities, using digital technologies, and improve the quality of training and services, in the process. So what we draw upon in the paper and we start with is the fact that there is this sort of dialogue that's framed around LMICs being the countries that need to adapt their health systems to be resilient for what is to come in terms of the impact of climate change. Whereas the mitigation agenda is very much framed around higher income countries. And we see a real problem with this. And partly because if we really worked in that way and did the same old stuff that we've done in the past in LMICs going forward, we would end up with more expensive, poorer quality, and more polluting healthcare. That is ultimately also unsustainable. And we don't want that. So we really would like and find it helpful if people were to see that LMICs really need to be part of this agenda, and that, as Jerome mentioned, when it comes to universal health coverage and the finance that's related to that, that we make sure that we deliver and find virtuous ways of getting donors to work with governments, and in our case, banks, to frame the agenda and the investments around net zero ambitions. And we, as I say, we have the data, we know we can do it. So this is not theoretical or just a sort of an empty call out without data. Yeah. But in the process of aiming for net zero, if I could, we can't forget the impact of the health supply chain. And this constitutes, and this is overlooked in terms of the COP26 dialogue, where health systems have declared their targets. They're overlooking and not talking about the fact that the supply chain constitutes between 70 to 90% of the total footprint. Yeah. And given that this sector is 55% more carbon intensive than the automotive sector, we can't overlook it. No. So we have a framework that is very much aligned with the NHS in terms of what we can do if we align governments and those with purchase power to influence the sector, to disclose primarily and adopt net zero targets, knowing full well that they can afford to do it because this is a very, very well financed sector. And the fact that we need to do this together, North and South, because the same suppliers provide for both and often source their products and conduct their production in all parts of the globe. And if we don't, we can expect some kind of carbon dumping in the future as some countries get more stringent and others don't. So we're basically calling for a joining of action, inclusion of LMICs in the mitigation agenda, but really reorienting some focus, not just around net zero, which we can do, but not overlooking the pharmaceutical sector in particular.
Yeah.
I hear you wanting to come in, and I'll reserve other comments below.
How can you tell? No, that's really, really good to hear. Thank you for that. The question I've got is people be wondering, how is it possible, as Jerome said, to increase emissions because the more healthcare provision is required, but achieve net zero? I guess what you're saying, and correct me if I'm wrong, is that one route to that is not repeating the mistakes of richer countries. And if that's the case, could you just say a little more about that?
I can say something briefly that actually, healthcare is very carbon intensive in many LMICs because there's a need to rely on, say, diesel generators to prop up inconsistent grid supply, but also, the sort of requirement for cooling technologies, or maybe, the fact that actually some of the technologies that have already been implemented and costed in higher income countries haven't made it, through to full implementation in LMICs. So there's a lot of options that we might, we might have already seen installed in high income countries that have already achieved big cost savings that are still not being delivered across the board in LMICs. So I think there's a lot of opportunity there to make really big cost savings and carbon savings at the same time by investing in some of the technologies that are good for efficient and high quality healthcare.
Great, thanks, Jerome. Fawzi, any quick comment on that before I move on?
Yes, well, there's also the opportunity to leapfrog, not just repeat, but leapfrog over the mistakes and do things differently. And often in LMICs, partly because, staff and trained staff in particular were sort of short supply, there's been a decade's worth of investment in community health workers. So there's a potential to, and that's already happening, it's not a new idea, but to connect them through available technology to better equip them with training digitally and with the tools with which to conduct their health promotion and disease prevention activities. And that's, not just low carbon, it can be made zero carbon. So, there are, and then what Jerome didn't mention was transport, which is another very big area, plus the sort of carbon intensity of the supply grids in many of the countries that we work in too, for which there are many opportunities to clean up. Thank you.
Great, thank you. Thank you both. I'll come back to both of you at the end again. Before I go to Anand, I'd just like to say, if you're watching, feel free to tweet during and after the event using the hashtag #BuildingBackGreener. That's hashtag #BuildingBackGreener. And also, this webinar will be available on YouTube within about 24 hours. Okay, so I've got Anand Bhopal next. Anand, you're also at COP26. Am I right? Yeah, you are. You look like you are. Right. You've got a delegate tag on. Your paper is on priority setting and net zero healthcare. I mean, the tricky subject of trade-offs. And I think you rather seductively, your title includes the words, how much health can a ton of carbon buy? What's the answer, Anand?
Well, let me cover that, Kamran, if I can. Thanks so much for inviting me. So, something that's clear from being at COP is the question is not why should we tackle climate change? The question is how. So we have to acknowledge that actually this conference by and large is about how. It's a debate on who should cut, from which sectors, by when. And we need to start having that level of discussion, I believe, within the healthcare sector. There's been great strides have been made in net zero commitments. I mean, this was really pioneered by the work of the NHS, and it's great to see so many other health systems joining forces here. And I suppose in this paper, what we are suggesting is we already have mechanisms of dealing with trade-offs. We call this priority setting. It's a discipline which really has been formalized over the last 30 years or so. And what this is allowing us to do is try and balance up different priorities. If you ask virtually any clinician in any specialty, they'll normally say they're underfunded, they could and should do more. They should have more. And I suppose what priority setting aimed to do was try and weigh up which ones are the best and optimal use of scarce resources. Now, money isn't the only problem. However, we're now dealing with what we term carbon scarcity. You may have heard of carbon budgets, the amount of carbon dioxide equivalents that can be emitted to stay within 1.5 degrees. Now, this can be reinterpreted to think about a budget rather than a financial budget, a carbon budget. So if you think of a carbon budget, we want to spend it in the most wise way possible. So we introduced this argument in the paper and present three faces to this argument. One is for clinicians. Clinicians have opportunities through quality improvement approaches to try and reduce emissions from their specific healthcare services and interventions they provide. The second and perhaps most important one is where how much health can a ton of carbon buy comes in. So what we look at is we look at conventional priority setting, which, for example, is used by NICE in the UK, Disease Control Priorities Project globally. And we say rather than thinking about, as was very pioneered about 25 years ago, how much health can $1 million buy, which was a good way of weighing up which intervention should we prioritize, we ask how much health can a ton of carbon buy? And it's purely for illustrative purposes in the paper, and I encourage you to have a look. But this is offering a bit of an understanding of some interventions are far more carbon emitting than others. I mean, we're not passing judgment on saying these things should be cut, just merely pointing out that some things get more health per ton of carbon emitted. Finally, and I think really crucially for this debate, I really enjoyed hearing from Fawzia and Jerome, is about global equity. You know, what is the role and responsibility of different countries? Well, just one passing comment on the COP26 health program. You know, it's great to see countries from all around the world committing to net zero emissions by 2050. However, is it appropriate for all countries in the world to have the same target? You know, should some countries be reaching that target far earlier? Should actually we be thinking not as health in a national way, but be thinking of the health sector globally? And if we start to think with a global perspective, of course, we'd want to cut faster in some places and a bit slower in others. So I'll hand back to you. Thank you.
Yeah, well, I'm going to pick you up on that. And so, I mean, you've asked the question. Can you answer it? The presumption is it shouldn't be the same. And if it's not the same, how are we going to differentiate?
The presumption is that it shouldn't be the same, largely because it just never has. And I think we, particularly when we're in a setting of, say, a webinar or really putting our heads together, we need to think of new ideas. So I think in the paper, I only had a chance to skim it from Fawzia and Jerome that was published today. They mentioned about making sure we meet universal healthcare coverage for all low and middle income countries. Now, I would agree that is a priority. That is a global priority for the health sector. Now, I am personally somewhat uneasy if we're talking about reducing emissions in low and middle income countries unless we simultaneously talk about universal healthcare coverage and providing the most basic level of care. So I wonder if it would either, and I think we have to throw this open to health policymakers to think, well, we are ultimately trying to reduce emissions for the good of the planet, not just for the good of our own people and our own countries. So perhaps we do need to work together, especially bearing in mind that we're talking about global supply chains for about 70, 80, 90% of emissions in most countries' healthcare systems.
Okay, I don't think I can see Fawzia's itching to come in here. Fawzia.
One of the things that we find when we sort of start to explain our work to colleagues, governments in countries that we're working in, and just to say that we're working in the Afghanistan, Syrias, Pakistans, East Africas of this world, is that until you start this journey and, in terms of benchmarking your own operations, you really don't know what can be done. And that's what's transformative. If you get to what we should all be doing, we would say, start measuring. And there are tools now that are available that weren't before, but that work in the hands of you and me. You don't need any background. And as soon as you start this, you do two things. You empower people to know what can be done, and then they become strong advocates. They understand the science, they know how to explain it, they go well beyond the health sector. Instantly. They can see what can be done in schools, they can see what can be done in waste management, they engage. And that's what we're finding in our countries with our colleagues. The other thing is that even we threw the challenge to staff to say, cost everything that you can possibly think of. Now you know how to calculate the carbon impact of each measure for 5 years. And we're finding that, every operation, hospitals to, downstream, can come up with, 75% reduction, 80%, and that's when they haven't even fully costed the list. So we know it can be done. And until you embark upon this journey, you don't have that faith. And so for us, we have net zero by 2030 as targets.
When you say us, who do you mean?
Sorry, the Aga Khan Development Network throughout. Okay, so health services, education. With health, we know we can do it. And there's, you try and tell someone to go slower because they're in a lower middle income country. They don't want to because it saves money. It provides the avenue to doing things better. So, and we don't want to be left out of this discourse or the funding. And we don't want to be building new facilities without building in measures that will make them sustainable and cheaper in the long haul.
Great.
So,
Good, thank you. I'm going to come back to all of you in a minute and ask you a bit more, because it seems there's an acceptance. We need to take action. The question is, and health is central. The question is how? How do we move from the rhetoric, from the talk we're hearing, to making it a reality and achieving the changes that we need to achieve? But quickly, I want to turn to my colleague Will Stahl-Timmins from the BMJ. Will, you've produced an infographic based on some of the papers that we've been hearing about. Would you like to just quickly talk us through that?
Yeah, thank you, Cameron.
And share it.
I'll do that. Well, why don't I? I'll do that now.
Thanks.
Is that working now?
Yeah, we can see it.
Great. Well, at the BMJ, we do like to go beyond just words. And so that's why we have things like podcasts, videos, webinars even, that we're on now, but also data visualizations and infographics to present information more visually. So when I was approached about this project, I was really interested to read through the papers, and I worked with Jodie and Jerome and Fawzia particularly on some of the ideas and strategies that are in their papers, and they were inspiring. But there were also quite a lot of them. They were actually combined. There were over 100 different strategies that we could have thought about sort of some way of presenting. So we were thinking initially about ways of presenting all of them in different categories, or linking the papers together somehow, maybe having different circles with all the different strategies around them, something interactive. But in the end, we came up with this idea of presenting just a small selection that would inspire people and get them interested and get them to think about what could be possible, and then ask, can we learn more by going into the papers and reading all of the other ideas. And we settled on this idea of a graphic which brings those out. Initially, we had a big hospital in a little town nearby, but then we realized actually healthcare needs to be more distributed than that. And we ended up with a much more kind of holistic view of an entire town, with a hospital, with localized health centers, with renewable energy sources, with all of those things together. And all credit to the illustrator that I worked with, who managed to turn this crazy sketch into something much more approachable, I think. And we were able to create this graphic, which I wanted to be a bit more like a sort of anywhere town. It has lots of little details within there, like there are some sloped roofs, which are more typical in higher latitudes, and there are some flat roofs, which are more typical in hotter countries. In terms of dress style, there are Indian saris, there are people in African dress. So this could be a town which is kind of combines, it's a virtual, it's a metaphor town, which allows you to think about 12 of these strategies that are presented in the papers, such as encouraging more active transport, such as thinking about what food is served in health centres and making that more local, more sustainable. It's got electric ambulances, as we've mentioned already. It's got even things like people doing a Tai Chi class in one of the parks. And the idea was to bring some of these ideas to life, to inspire people to think more about these issues and learn more about the hundreds of ideas that are in these two papers together. And I hope that it will achieve that aim.
Great. Well, thank you for producing that. We had a deep insight into how your brain works there. It's really helpful. The visual, are you calling it data visualization or an infographic?
This one is an infographic.
Okay. All right. The infographic is available on our website.
It is indeed. Yes.
Great. Thank you. So I'm going to give you all a minute, which we're tight for time. The question is how, and I'm going to go to Jodie first. Renee, I'm going to finish with you just to kind of sum up your thoughts from COP26 and what you think, how the future will go. But back to the authors in order. Jodie.
So the question is how?
Yeah, I mean, how do we turn the rhetoric that we're hearing, and really good, you know, it's really encouraging. How do we turn that into something concrete?
Well, on the clinical action, you know, really, particularly, this applies to high and low income, but especially high. We need to address our overuse and misuse of resources. And I think it's really important to say that we really haven't had the opportunity to talk about what we really mean by net zero, which is, you know, reducing value chain emissions in line with the 1.5 degree warming limit pathway, but we have to balance remaining emissions with appropriate carbon offsets. So we're never going to get to this, you know, perfect balance. We're always going to have to do some offsets. And it's also important to point out that even though this is about climate change, there are other pollutants of concern, chemicals, pharmaceuticals, macroplastics, which are of course derived from fossil fuels. If we don't address our inappropriate misuse of these resources, we can't get to where we need to be. So how do we do that? Firstly, it starts with individual action as a clinician, what I do in my personal practice, and identifying those barriers that are preventing me from inappropriate care. And again, that's high and low combinations.
Great, thanks, Jodie. I'm sorry, I would get more of an answer from you, just that time is tight. Jerome. I think you may be on mute, Jerome. That old cliche now.
Yeah. Somebody had to.
Yeah.
Well, I mean, to my mind, it's better to sort of think about, you know, where the emissions are actually coming from. You know, what's burning, what's leaking, whose responsibility is it, and how do we get it to stop? You know, as simple as that, really. I mean, and there are very few actual emission sources. I mean, in some cases, it's known products like anesthetics and inhalers, where we absolutely need to focus. In other cases, it's healthcare buildings and vehicles. And usually, addressing those also saves money, as well as saving carbon emissions. And otherwise, it's usually the healthcare product manufacturers and suppliers. So we need to put in place measures only to buy from those suppliers and manufacturers who are committed to achieving net zero as quickly as possible.
Yeah.
And if we can address those three things in that way, you know, and actually we have the prerequisites of prevention, efficient and appropriate care and waste reduction always, you know, but if we can address those three things, we'll be a long way further ahead.
Great. Jerome, thank you. Fawzia.
Yes, I've already said it, but I'll say it again.
Okay.
Start with benchmarking your operations, because it's an education in itself from which there's no turning back.
Yeah.
And you know, you turn what Jodie voices concern that all health workers have with an informed approach to what matters and what does not, or what can be left till a little later. So that's first. The second is not to forget our agency as trusted advocates in this space. And I think it was Renee who spoke to how that's, you know, becoming more mainstream. And in the process, I expect we're going to have to rediscover what it took to get tobacco, for example, out of health, you know, the debate on health, and to apply some of not only that strategic knowledge of advocacy at that political level, but to remember we're not just good advocates, but we have political clout. And in LMICs, that's probably more true than elsewhere, and we should use it.
Great.
Thank you.
Fawzia, thank you. Anand.
There's inevitably low-hanging fruit here where we can reduce carbon emissions and improve health and save money. We have to acknowledge there may be a time soon enough where these may be in conflict at times. And we have to be thinking rationally, bringing our scientific mindset to dealing, anticipating and dealing with those trade-offs. We suggest priority setting is a good framework for this, but there may well be others. But I just encourage us to start thinking in terms of what happens once we get beyond the low-hanging fruit. Thank you.
Great, and then thank you. Renee, final thoughts from you. Are you with your dramatic backdrop there? Have we genuinely made progress? Does it feel different from last time? Where do you think we need to go now?
Yeah, I mean, the reality is that every fraction of warming is already harmful to health and worsening inequities and disrupting our healthcare system. So no matter what happens at the conclusion of COP26, we can celebrate the wins here, but there is so much work to do, and what is happening here is long overdue. So as an emergency medicine doctor, I mean, climate change is a health emergency, and we need to treat it like an emergency. So we've made the diagnosis, countries are stepping forward and committing, which is wonderful, but now the hard work starts of evidence-based treatment. And when a STEMI comes into my emergency department, we activate every lever and move urgently in order to get that patient the treatment that they need. And we need that now. So action on climate change is critical to our mission, universal health coverage, improving health. If we don't do this as a health sector in order to catalyze societal change, I don't know who will, but people are filling the room and action is happening. We just need to continue to accelerate. Thank you.
Renee, thank you. I think you've helped us all conceptualize that. Treat it like a STEMI coming into the emergency department. Thank you so much for all of your time today. Really appreciate it. Thank you for writing your papers. They're really informative, very, very interesting. All available on bmj.com. Appreciate Will's infographic. And Renee, thanks for your time joining us from COP26 along with Anand there as well. So Fawzia Rashid, Jerome Baddley, Jody Sherman, Anand Bhopal, Renee Salas, Will Stahl-Timmins, thank you very much. And of course, thank you to Fiona Godlee, our editor-in-chief, for her opening remarks. I'm Kamran Abbasi. Thanks for joining us today on this webinar. Goodbye.
Thank you.
Thank you.
Thank you.